Today, Haley Maxwell and Kat Walker will be discussing emergency C-sections. Outline. For our presentation, we will discuss non-emergent and emergent indications for a C-section, categories of an emergent C-section, decision delivery interval, anesthesia considerations, post-delivery complications, and we will discuss a case report involving an emergency C-section. Indications for a C-section. There are indications for a C-section that involve non-emergent and emergent indications for a C-section. Cephalopathic disproportion is a non-emergent indication for a C-section, and this is when the baby's head is too large to fit through the mother's pelvis. Arrest of dilation means failure of labor to progress. Malpresentation, which means breech, prematurity, prior C-section, and prior uterine surgery may be affected by scar tissues and an increased risk of operative bleeding. For an emergent C-section, hemorrhage remains the leading cause of maternal mortality, causing 25% of peripartum deaths. Risks of hemorrhage in the parturient include placental previa, abruptio placenta, and uterine rupture. Another reason for an emergent C-section includes non-reassuring fetal heart rate tracings, such as recurrent late decelerations, recurrent variable decelerations, and bradycardia. Categories of emergent C-sections. There are 4 categories of emergent C-sections. Category 1 is a C-section that must be immediately done because there is a threat to the life of the mother or baby. Category 2 of emergent C-section involves problems affecting the health of the mother and/or baby but are not immediately life-threatening. The decision to incision time for Category 2 is about 30 minutes. Category 3 is that the baby needs to be delivered but no immediate risk to the mother or baby. And Category 4 is that the C-section will take place at a time that suits the mother and the OR team. Realistically, most emergency C-sections are a Category 2 and are mostly done within an hour after the decision is made to perform a C-section. Life-threatening Category 1 C-sections should be done within 30 minutes. We will talk more about Category 1 examples on the next slide. Category 2 examples include breached presentation of the baby, previous C-sections while having a baby while in labor, and non-reassuring fetal status such as heart tones. Category 3 examples include low amniotic fluid index and previous C-sections not in labor, and like I said, Category 4 is an elective C-section on the mother and obstetrician's time. Category 1 examples. These are some examples of a Category 1 that would warrant the use of an emergent C-section. These examples include amniotic fluid embolism, urgent C-section with potential for massive hemorrhage of the mother, massive hemorrhage, prolapsed cord for the baby, profound fetal bradycardia, maternal hemodynamic collapse, and eclampsia and active maternal seizures. Decision delivery interval, also abbreviated as DDI. The DDI is the time elapsed between the time the decision is made for the emergency C-section and the time of the delivery of the baby. Hospital protocols and interventions are designed to minimize DDI and in an attempt to prevent maternal and fetal mortality and morbidity. The goal is less than 30 minutes. The 30 minutes are broken down into categories, which would realistically be 5 minutes for transporting the mother back into the OR room, 5 minutes for draping and prepping the patient, and the rest of the time is for anesthesia and delivery of the baby. According to the American College of Obstetrics and Gynecology, the surgical delivery, like I said, should be less than 30 minutes. There is some evidence that DDI greater than 30 minutes does not correlate with negative fetal outcomes. This is important that we as anesthesia providers know this so that we can understand the urgency of a C-section so that we know how to quickly respond to help protect mother and baby. Emergent C-section procedures. In an emergent C-section, it is important to have clear, concise, and verbal consent for the patient. This is acceptable. The patient is transported to the OR at this time in a fast and safe manner as quickly as possible. The induction and possible incision can happen simultaneously. Most of the time, incision is made after induction. Communication with the OB surgeon is essential so that the incision can happen promptly and the baby can be delivered. Delivery of the fetus occurs through a horizontal or vertical incision made by the surgeon or OB. The fetal head is elevated out of the pelvis and delivered. The cord is clamped. The placenta is removed manually and the incision is closed. This is a rough breakdown of what happens as the mother comes into the operating room for an emergent C-section.
Anesthesia considerations for an emergent C-section. The goal of a Category 1 is rapid delivery of the fetus when there is a threat to maternal or fetal life. There are certain risks that we need to anticipate, which include difficult airway, hemorrhage, and aspiration. Your pre-op assessment may occur on the way to the OR, and it should be a rapid, focused assessment to determine risk. If you have time, pre-oxygenation should occur, but sometimes during a true Category 1, pre-oxygenation may not occur and is limited to 4 deep breaths of 100% oxygen. If it is a Category 2, you may have time to do your 3 to 5 minutes of pre-oxygenation, but keep in mind that with pregnant patients, they have a reduced FRC, as much as a 40% reduction from baseline, which will decrease your apnea threshold. The position should be left lateral uterine displacement, and you will perform an RSI on these patients for induction. The 2 most common drugs used is succinylcholine and propofol. You can use etomidate and ketamine. This is a good case to have an extra set of anesthesia hands, and this is due to having to hold cricoid pressure and to have another set of hands for all the potential things that could go wrong, like aspiration and difficult airway. Sometimes these patients don't have an IV, so you may need another person to do that. You should avoid sedatives and opiates until the cord is clamped. And remember, there is a difficult airway algorithm, and you should have equipment like the video laryngoscope, short handles, and smaller ET tubes to compensate for the edema that can occur in a pregnant patient. Epidural versus general anesthesia. RSI for general anesthesia is the choice for Category 1 C-section unless it's contraindicated. You can do an epidural if time permits, but on a true Category 1, you will not have time for neuraxial anesthesia. This can happen maybe with a Category 2 through 4. So if you do have an epidural in place and an emergency has occurred, you could redose the epidural, but this is made on a case-by-case basis. So it is good to communicate with your team to know how the mother is progressing and if there are any potential problems on the horizon. It also will help us determine the case-by-case basis by considering the current condition of the fetus and the maternal state. So with general, we do have to consider our aspiration risk. If we do have time, the patient needs to have bicitrate or sodium citrate before coming back to the OR. You can also administer H2 blockers and a prokinetic like Reglan. And you should consider the patient with post-op nausea vomiting. So remember, all pregnant patients are considered high risk for aspiration due to the relaxed esophageal sphincter tone caused by progesterone. There is a third option which is rarely considered, which is local infiltration in a C-section, but the literature on that is pretty rare. Intraoperative care includes our standard monitors, including end-tidal CO2. Our volatile of choice as maintenance is usually with sevoflurane, even if the literature does support isoflurane. Now, in the literature, it says that nitrous oxide is preferred by some providers because of its rapid onset and intraoperative analgesia. Careful consideration is required with the use of nitrous due to the aspiration risk and its potential for post-op nausea, vomiting, and it should be administered after delivery due to birth defects. Our patients should be extubated awake. The risk of failed intubation in pregnancy is 8 times higher than the general population. Therefore, it is important to ensure extubation criteria is met and that we give a full reversal. You will be administering oxytocin, and we'll discuss this more on the next slide. The typical blood loss with an emergency C-section includes 750 to 1,000 milliliters. After delivery, our anticipated problems, and this is just a short list of the things that could potentially happen to us with the maternal uterine atony. That is what our prophylactic oxytocin is for, to decrease the risk of this. Post-op nausea, vomiting, hemodynamic instability, and hemorrhage. Fetal complications that could occur. General anesthesia is associated with lower neonatal EPGAR scores at 1 minute compared to neuraxle. However, the EPGAR scores at 5 minutes are comparable. So remember, our primary responsibility is to the mother. A neonatal team will be in place to take over fetal care for us so that we can focus on mom.
In our case report that we will discuss, it involved a 30-year-old mother, gravida 3, para 2. This mother had a history of a DVT at week 10, and the patient had an IVC filter placed at this time. The patient was placed on subcutaneous heparin for the duration of her pregnancy. Her last dose of heparin was 12 hours before her hospital arrival. Neuraxial anesthesia was contraindicated in this patient due to her history of anticoagulation and an elevated PTT. The anesthesia providers confirmed and decided for emergency bedside delivery given the ongoing difficulty with a two-handed masking technique due to muscle rigidity and non-reassuring fetal heart rate status. Her difficulty to being bagged came secondary to a remifentanil accidental overdose, which I will explain later. The patient was given remifentanil for labor pain because neuraxial anesthesia had been contraindicated for her. The scalp electrode for the baby to monitor the fetal heart rate did not detect a fetal heart rate after she was administered remifentanil. The referential diagnosis for the decreased fetal heart rate tones included a massive PE potentially, amniotic fluid embolism, intracranial hemorrhage, primary cardiac event, or an adverse medication reaction. At this time, it was made to have a decision for emergency C-section, and this emergency C-section was performed with a low midline vertical incision 4 minutes after the baby had lost its fetal heart rate tone. The mother ended up delivering a term female. During her intubation, she was given IV etomidate 20 milligrams and succinylcholine at 120 milligrams to help facilitate her intubation for her emergency C-section. This was administered at the time of surgical incision to help facilitate her intubation as well. Hysterectomy and abdominal wall were temporarily closed in labor, and she was transferred to the OR where her abdominal cavity was inspected. At the end of her emergency C-section, the patient was extubated and was taken to the PACU for extended monitoring. Her delivery was complicated by her wound separated, but the patient had no intraoperative recall of her delivery. The baby was eventually transferred to the NICU for closer monitoring, and the baby was okay. In conclusion to this case report, her difficulty to mask bag her was actually due to a medication error where the remifentanil concentration was 10 times higher than normal and was incorrectly labeled on the syringe by pharmacy. As a result, for her labor pain, she was bolused a 400 mic bolus instead of a 40 mic bolus. This led to her chest wall rigidity and quick desaturation, which ultimately affected the baby and caused decreased fetal heart tones. This was unknown at the time, but the quick decision of the surgical team and anesthesia team to bring the patient back for a stat C-section saved the life of mother and baby. It is extremely important to understand the procedures and processes that go into an emergency C-section to help ultimately save mother and baby. This case report, even though it was a medication error, had a positive outcome. The delivery of the baby in this case had occurred in 4 minutes, which is pretty close to the 3 minutes that people normally want. This case report is super important to take into consideration when we as anesthesia providers will be performing emergency C-sections. Thank you for listening.
In summary, communication and preparedness is essential in emergency C-sections to ensure safe maternal and fetal outcomes. Anesthesia should be proactive instead of reactive in emergency C-section cases. So remember the benefits versus the risks related to neuroaxle and general anesthetic, and it varies on a case-to-case basis. And our goal is rapid and safe delivery of the baby.
Thank you for listening to our presentation. These are our references that we use to create our presentation. Thank you.